Welcome to the Oncology Journal Club Podcast, a fun and educational oncology learning resource for medical professionals. I'm your producer, Rachel Babin from the Oncology Podcast. I'm joined by our esteemed hosts, Professor Craig Underhill, Dr. Kate Clarke, and Professor Christopher Jackson. Today's episode is an ESMO digest. CJ gets us started with key upper and lower GI data. Kate covers pembro and HIV-associated Kaposi sarcoma, as well as neuroendocrine tumours and triple-negative breast cancer. And Craig talks us through the GU and lung updates. There's so much analysis packed into the next 40 minutes, and a few cringy dad jokes too, of course. For additional insights and links to the papers, visit the show notes on oncologynetwork.com.au. The Oncology Journal Club Podcast is produced with pride by the podcast team at the Oncology Network. Thanks for listening.
G'day, kia ora, kia ora. Welcome to episode 11 of the OJC Trans-Tasman version of the OJC podcast. Great to have you all listening in. We're getting some good feedback on recent episodes and increasing listenership, which is great news. Hello, Dr. Clarke.
Hey, kia ora, Craig. How are you?
Good. Professor Jackson, how are you?
Kia ora. Pretty good, thanks very much, Craig. How about you? I heard you were not at an awards dinner last night. What's going on with that?
Oh, I was in Sydney, so I didn't go. And so myself and Professor David Thomas won an award in the medical excellence section of an industry award for, I think it's about communication. And so I recorded a podcast interview with David last year about the Omico program and the Prospect program, which is enabling next-gen sequencing for all patients in Australia with advanced cancer and then plugging them into clinical trials. So we had a bit of fun doing the podcast and got this industry award.
So you're officially an award-winning podcaster. Well, it's great to have an award-winning podcaster on our team.
It's true. I can
sell that and add that to our tagline.
Yeah. And our shout-out to our extensive listenership obviously worked recently, Chris, because we just sort of segued into mentioning that you were running for the UICC and you were elected to the board, is it, or a committee?
Yeah, the board of directors. So thanks very much to all the listeners who got their organisations to vote for me. So the UICC, as many people know, is the political membership body for cancer policy and global oncology. And every member organisation gets to vote for their 16 directors. And so I went to Geneva and I campaigned on being a pretty good third choice. I told people I didn't mind if they voted for someone else as their first choice because there's a lot of people better than me. Actually, there's an awful lot of people who are second better than me, but I'm actually not bad. I'm probably third. So vote for third. I had a T-shirt made up which said Chris Jackson, pretty good third choice, with a big picture of a Kiwi. Went around and it seemed to do the trick. That and the OGC podcast on the board.
Fantastic. And first ever Kiwi elected.
First ever Kiwi-based, yep. Sencha Aranda was the president of UICC. Now, not many people know that Sencha was actually born in Winton, which is in New Zealand. But Australia claims Sencha as their own these days, and she was based in Australia when she got that. So first New Zealand.
We know that. We know. She's got that accent.
But Australian accent. Anyway, forget the data. Let's get to the data.
So we're going to focus a little bit on the ESMO meeting. There's been a lot of post-ESMO meetings held in Australia, I presume in New Zealand as well. Some interesting data. So we're just going to sort of look at some of the top line, maybe some of the practice changes from that meeting. Chris, I went to the meeting and I must say it's getting so big. There was something like 30,000 attendees. It was really interesting. You know, you can get ribbon envy when you see people walking around with the ribbons on their badges, but I noticed that a really tiny proportion of people are ESMO members. And it's so expensive to attend now. I was thinking they really should give a really substantial discount to the members because it's a big money spending thing and a lot of industry people. And one of the things that disappoints me about the meeting is they have industry-only forums over lunch. So there's nothing else on, and you kind of, you know, if you want to go to a session, you kind of have to go to an industry session. So it's an interesting meeting, got so big. I think it needs to maybe go like ASCO and just unfortunately have it in the same city every year that's accessible with flights, accommodation, and it's not plonked way out of town somewhere, which the conference centre in Barcelona to come from towns nearly 45 minutes or an hour by public transport. So it's always fun going, but, it's a big money and time commitment. And then when you get there, the sessions are full and then the overflow rooms are full. And everyone's sitting in the corridor on their laptops watching the presentations on their laptops, which you could do in the comfort and safety of your own home. So it's good fun to go, but it's not all a bed of roses at these meetings now. I think they've got almost too big.
Yeah, well, and I think that the conferences certainly have to add a point of difference. I mean, the online experience these days is so good. So if you just want the data, you get it better online than you do in person. So it's still that networking, which is really important. And part of that networking is what happens in the evenings, isn't it?
That's right.
And also having people around you where you can actually sit and discuss the data in more detail. I think people from Australia and New Zealand just have a real sense of how far away these places are because it's, day and a half to get there most of the time, recovering in totally different time zones. So it's a challenge.
Yeah.
So I tend to go to one a year, really. Haven't been to ESMO for a long time because it is a very long way away.
I think, though, Chris, to the other issue perhaps is these European cities aren't set up to house 30,000 people within walking distance.
Yeah.
Unlike Chicago, which really is.
Mm.
When you and I were in Vienna many years ago, we were miles away from the conference.
Yeah, that may have been an accommodation expense choice. Barcelona is one of my favourite cities. I love the tapas. I love the beaches. I love the temperature in July when World GI Congress is on. It's a lovely, lovely, lovely place.
It was great, and it was great catching up with some people. And that's one of the things, for regional people as well. We maybe don't see our colleagues face to face as much. So it was great catching up.
No, that's right. I'm really pleased to see as well, Craig, that you're very careful with your suntan because you're still, with your sun cream, you're still pale as all buggery. So, it's good to see that you've taken good care while you're over there.
All right, let's get into it. I think, Professor Jackson, are you going to go first and tell us what you thought some of the highlights?
Yeah, thanks. I was going to cover off the GI stuff today. First of all...
Gee, there's a surprise.
Oh, yeah, what a surprise. I'm a one-trick pony. No, two-trick. I do upper and lower GI. There you go. The Podium 303 study, or Interact 2, was presented at ESMO this year. Podium 303, maybe they named it optimistically to get themselves on the podium. But this was in patients with previously untreated, locally advanced or metastatic squamous cell carcinoma of the anal canal. And this built on the Interact study, which defined carboplatin and paclitaxel as the preferred chemotherapy backbone in anal squamous cell carcinoma, and understanding that as an HPV-driven cancer, the TMB is often quite high, and so there is a potential role for immune therapy. Previously, we had data for second-line therapy with immune therapy in anal cancer, and this is the first time it's been combined in a randomized study. So this study randomized 308 patients, so it's the largest ever anal cancer study, to either carbotaxol placebo or carbotaxel, let me see if I can get this right, retifanlimab. Now, that is not people who are fans of our Health Minister, Shane Reti, but retifanlimab. Hans, you can call in and tell us that I've got it wrong.
Is that a Kiwi dad joke?
Yes. And retifanlimab, I should say, is the Insight PD-1 monoclonal antibody. So it's PD-1 inhibitor. The primary endpoint was progression-free survival, which was met, with the median PFS going from 7.4 months to 9.3, which is a grand total of 1.9-month extension. Hazard ratio was a tasty 0.63. When you look at the PFS curves, it's good to see the PFS curve is flattening at around about 12 months, which is suggesting that with longer follow-up, maybe we'll start to see that plateau that you see in other cancers, but I think that's a little early to see. And there's no early crossover of the curves as there is in PD-1 monotherapy studies. OS is immature but promising, and currently the readout on OS is plus 6 months. This may be a situation whereby the OS is better than the PFS by some order of magnitude. There are other studies in particular going on with modified DCF, with atezolizumab going on, which is a single-arm phase 2. So we should see some more randomized studies. But I think this pretty much is the high watermark in metastatic anal squamous cell carcinoma. And most people will consider carbotaxol with a PD-1 inhibitor now the standard of care. So I think that's an important study. Small gain in PFS, not OS reported yet, but I think people are going to accept it.
I feel like my rebuttal I could just put on play. I could just push a button and go, you're combining two agents versus not combining those agents. Is this current versus sequential? Have we got any evidence? Blah, blah, blah. So I feel very much like, same thing, different day. it's really hard sell when people are self-funding drugs to say, at this point with this early data, your disease may stay asleep for a month longer than if we didn't do it. It's tricky. But the problem is, of course, every human doesn't get another suck of the sab, for a less crude expression. They only get one chance. And some people will be willing to pay that. Right?
Yeah, I agree with that, Kate. And I also think that is why we need to have the OS data available so we can really help people understand it if it's going to help them live longer and not just control their tumour on a scan for longer. And that's why OS is such an important endpoint. And I agree with you around the crossover, is it early, is it late? And that's why you need the paper to see what the what the crossover was and see how many people had it. And that's a situation where people should have had access to crossover because we know it's active in second line. Lots to cover, the Top Gear study. This was an AGITG study which had been going on for many years. We recruited some patients for this. This is in gastric cancer. Now, this was conceived in the era where perioperative chemotherapy was a standard and people debated the role of postoperative chemoradiotherapy. So that was the McDonald study, surgery first followed by chemorad, and then perioperative ECF. They were the two standard treatments at the time when Top Gear was conceived. They could see the Critic study that was looking at post-op chemo-RT following on from neoadjuvant chemotherapy. And so AGITG looked at pre-op chemoradiotherapy and ECF versus ECF chemo. It was later modified to include FLOT, and to cut a very long story short, unfortunately, it was an absolutely and utterly plumb negative study. OS curves you can't even get a credit card between, so that negative. The secondary endpoints of PCR were better for chemoradiotherapy, which just reinforces, Kate, this is where I push my replay button. Isn't PCR a rubbish endpoint when you're looking at comparing chemorads versus chemotherapy, and doesn't translate into necessarily overall survival. So chasing PCR is not necessarily the endpoint that we think it is, certainly in ones where you have a high rate of systemic relapse. So that was a shame. A lot of people in Australasia put a lot of effort into that study. Trevor has been a servant of the Australasian GI community running that study for so long. It'd be heartbreaking for the investigators, but of course actually heartbreaking for the field not to have it advance as well.
Yeah, it was, but it's important, I think, an important negative study, practice changing, because there's still a lot of centres in Australia that are giving this approach. And now I think people will switch to the perioperative FLOT chemotherapy for fit patients. This study was published in the New England Journal, which is, we've often disparaged it as a journal of positive results. But this negative study was published in the New England, and because it will change practice, I think, and in resource constraint times and resource constraint countries, not pointing any fingers, it's and in regional areas where people sometimes have to travel and displace for weeks on end to receive these treatments, it's good to know that the treatment's not needed. So, kudos to Trevor and all of the people at the AGITG and all of the investigators, patients and their families who are recruited to this important study.
Yeah, you look at a study in a different way when you see some of those numbers on the Kaplan-Meier curve underneath it, and you know that they're patients you enrolled, you look at a study in a very different way when you see it like that.
That's exactly right.
Keynote 811 was also reported. Now, Keynote 811, it's another of the Keynote Checkmate bunch of numbers studies. This was for HER2-positive gastric adenocarcinoma. Now, HER2-positive gastric adenocarcinoma, metastatic disease, the standard of care is chemotherapy with trastuzumab since the days of the TOGA study, where certainly IHC 3+ patients got a 5-month boost in overall survival. And so that has been the standard everywhere. Just become the standard in New Zealand this year. Kate's trying to suppress her laugh. Just become the standard of care in New Zealand. Now it's generic. Anyway, this is an important question because Keynote 811 randomized patients receive standard of care chemo with trastuzumab to either that chemo with either pembrolizumab or placebo. Now, this actually reported early with response rate, and when it reported early with response rate, the response rate was more than 50% with the 4 combination, with the quad, with the pembrolizumab included, and a lot of people jumped at that time and moved straight to chemotherapy, trastuzumab, pembrolizumab, and I certainly had a lot of patients ask me about it. They pushed it. Anyway, the final overall survival results have come back, and there's an improvement in OS of 3.2 months with a hazard ratio of 0.8. So a very minor proportional benefit, 3.2 months there in overall survival. The curves separated mildly. There doesn't seem to be any suggestion looking at those curves of any particular subgroup who's going to benefit, tease out, and the PFS is a measly 1.9 months. So OS of 3.2 months is at the lower end of the ESMO magnitude of benefit scale. The hazard ratio of 0.8 is at the lower end of the ESMO magnitude of benefit scale. But it's important to note that the chemo trastuzumab arm performed well at 16.8 months compared to, say, 15 months, which you might have expected from historic data. So it did okay. So I think, again, that'll be adopted because people will take any OS gain, but it's a small step forward.
Fantastic.
Yeah, other ones to cover off zolbetuximab, and again,
how did you say that?
Zolbetuximab.
And there was a bit of hype about this.
This is the Spotlight study. I prepared this when it came out a couple of weeks ago, Craig. I'm looking at my notes. They're now quite...
This is the anti-Claudin 18.2.
Yeah.
There's quite a number of those in development, I understand, but this was one of the first presented studies, zolbetuximab. We'll all have that rolling off our tongues.
We will indeed. Claudin 18.2 has only been a target for 2 or 3 years. This has come through the development pipeline really quickly, hasn't it? As a biomarker and as a single arm phase 2. And now we've got PFS analysis from Spotlight and Glow. 1,072 patients are randomized to zolbetuximab or the placebo group. So a very, very large study. In the combined analysis, the median PFS was 9.2 months in the zolbetuximab group and 8.2 in the placebo group, as a ratio 0.71.
Is this called a filibuster? You doing this in partner? Or?
Median overall survival 13.7 versus 16.4 months, hazard ratio 0.77. So again, a modest increment there, a modest increment. I would show you the PFS curves if this was a video podcast. Again, a modest advance there, and there's a flattening of the zolbetuximab curve in PFS, but there's very small numbers, so it'll mature a wee bit more.
So, Chris, the target, the anti-Claudin 18.2, do you know off the top of your head how many people with gastric cancer or GOJ cancers overexpress the anti-Claudin 18.2? And was this was an enriched population for that? Is that correct?
That's correct. They had to be 18.2 expressors. So I did present this at the ESCO podcast a couple of years ago.
Yeah, I reckon it's about 30%. Is that right? It's quite, or 20 to 30. It's quite a reasonable number, but it's not the majority.
So Claudin 18.2 was more frequently observed in early gastric cancer, 30.2%. So yeah, it's about 20 to 30%. It's different according to geographic location as well. So particularly high in Europe and Middle East. So there's geographic variation as well. So I'm sure we'll see that done according to molecular subtypes in time to come.
All right. And you're telling us about Ponsgromab, speaking of tongue twister, new products?
You have to work on the catchiness of their names, aren't they? Ponsgromab. Someone.
It's going to be called Ponzi, isn't it? Or Ponzi.
But cancer cachexia is a really big problem, right? I think anyone who's worked in the clinic will know how big a problem cancer cachexia it is. It's meaningful to patients, associated with sarcopenia, associated with reduced activity, increased fatigue and the like. Cachexia is strictly defined as a 5% loss of weight in the last 6 months, which with a strict definition, that's probably stricter than I would use. We tend to use 10% weight loss, but that is the strict definition is 5%, or 2% weight loss if your BMI is less than 20. So if you're already at a low point, it's only a very small change in weight. Previous studies have shown that the level of growth differentiation factor 15, GDF15, which is a cytokine, is increased in cachexia. So this particular therapy is a monoclonal antibody targeted against that cytokine. It was a randomized placebo-controlled study with 4 arms. One is placebo and the other 3 are increasing doses of Ponsgromab. And the main finding was that with the highest dose of Ponsgromab, the weight gain over 12 weeks was up by 3 kgs. So is that meaningful? Well, it could go up by 3 kgs if you're retaining fluid. So you have to look at other things like muscle mass and functional outcomes. Well, anorexia symptoms were improved and electronic activity monitoring, i.e. Fitbit, was also improved as well. So patient functional outcomes and anorexia symptoms improved also. So I think we can expect to hear more about this drug. We're going to hear more about the duration of therapy. and we'll be hearing more about muscle mass. There are some concerns with the study. It wasn't corrected for multiple testing when it's a 4-arm study, so that does reduce its power with limited racial diversity in the population as well. So they are other problems. They use Bayesian analysis for that as well, which I don't understand well enough to offer them for.
Fair enough.
So they were the ESMO highlights from me, and of course, Team New Zealand doing very well in Barcelona at the moment.
Fantastic. Quick question. The ponzigramab, that's a MAB, so presumably it's a monoclonal antibody.
Yeah.
And is it an IV treatment given with their other systemic therapy or?
I can't tell you off the top of my head, Craig, was IV or subcut, but yeah, it was given every 4 weeks for 3 doses for a total duration of 12 weeks.
Great. Okay. No doubt it'll be expensive. And Kate, we've talked before about other olanzapine, which is pretty cheap. So
very cheap. Yeah.
So
but 2.5 milligrams BD, throw it around. Great stuff.
Oh, you betting not once a day, Kate?
Yeah, throw it into my little pancreatic cancer lovies. Yep. And Creon.
Yeah.
Please think about Creon.
100% Creon and olanzapine.
Yes.
So this, to get a listing in Australia, would have to be very efficacious and very much cheaper compared to the comparator. So, which presumably would be olanzapine. So it'll be interesting to see going forward what happens with this drug. So look, all of those studies you mentioned, Chris, just for the listeners, they can click on the links, cliquez dessus. They're all being concurrently published in the New England Journal of Medicine. And so we've put the links in the notes. Were you going to mention the 10-year data for Ipi-Nivo?
No, because I've not reviewed it.
Okay. So there was some interesting data presented, 10-year follow-up from the original Ipi-Nivo studies in melanoma, showing long-term survivors, I think, of about 35-40%, which is interesting, and clear plateau on the curve.
I would love to hear what a brand new oncologist, maybe somebody who started training after these things were invented, they're like, oh yeah, you give immunotherapy to melanoma. Some people do well.
Yeah, that's right.
We remember everybody dying.
Yeah.
Right.
The DTIC era, and interferon and the like, it was a pretty desperate time affecting young people in such a devastating way.
Yeah, it was. I remember so many, patients you looked after young, including one of my best mate's brothers, who was a dynamic young lawyer in his late 30s who, died reasonably quickly. And so the landscape is completely different. And we just hope that, this is a first generation IO checkpoint inhibitors. Can we push those plateaus up? That's the hope, isn't it? Kate, I know you're going to tell us about breast cancer, but I think you've got a couple of other interesting things. You've got a NET paper and a Kaposi sarcoma, again, currently published in the New England Journal.
Well, I have to tell a confession that actually I think the Kaposi's paper was first presented at ESMO 2023, but it has recently been, the full paper has recently been published. So this is from Fred Hutchinson, Dr. Lorraine, Cancer Immunotherapy Trial number 12, pembrolizumab in HIV-associated Kaposi sarcoma. So for those of you who don't treat Kaposi's that's HIV-related, the first thing you do is treat the HIV. Many of the Kaposi's disappear. A young woman of mine, for example, went from an albumin of 10 to being completely well and as soon as she reconstituted her immune system. Interestingly, maybe because of the population of HIV-positive patients in the States, they use only cisgender men. Anyway, these gentlemen all got 200 milligrams of pembrolizumab Q3 weekly with a response rate overall of 62% and 88% of the first line. Progression-free survival of 28 months and duration of response not reached.
So 200 milligrams of pembrolizumab.
Pembrolizumab, gives you these stonking response rates. Interestingly, that is a similar response rate that you see in Pacley, but a much longer duration of response. So interesting. And also perhaps puts paid to the fact that many HIV-positive patients are excluded from immuno-oncology trials. And 25% of patients did end up with toxicity that required steroids, but no grade 5s.
So in the context of modern HIV treatment, how many patients now actually go on to develop Kaposi's that need treatment? Because if we're getting much better at actually controlling the HIV, which you mentioned was the first step.
So I have been back in my current role for more than 10 years, and we have seen 3 patients And we look after a community of 700,000 with a big refugee population. And without identifying these people, the vast majority had, for some reason, not had access to HIV therapy.
Yeah. Okay.
Yeah.
Fantastic.
Right. My second one is a neuroendocrine tumor one. And after telling Professor Jackson off about presenting progression-free survival data without OS data, I'm going to do the same thing. So this is heavily pretreated patients with NETs, and they separately recruited and reported pancreatic and extra-pancreatic NETs.
Yep. And
they gave them cabozantinib at a 60 milligram dose, which if you've given it is quite stonking, versus placebo. And in the pancreatic lot, PFS went from 4 months to 14 months, with only an overall response rate of 20%. But that's what that disease does. And in the extra pancreatic, progression-free from 4 months to 8.5 months. Most patients were grade 1 or 2, a couple of 3s in there. 65% had grade 3 toxicity or greater. And just in case you're interested, their previous treatments, 95% somatostatin analogs, 60% PRT, 80% everolimus, and depending on whether they're pancreas or extra pancreas, 60 or 30% temozolomide with or without cake. So, quite heavily pretreated patients. So that's another option.
Fantastic.
And then my final one, so that we've talked about a lot, Keynote 522, Schmidt et al. From Barts in London, finally the overall survival data, and the absolute difference of adding pembrolizumab to neoadjuvant chemotherapy in an unselected population of triple-negative breast cancer patients is 5%, and it's real. Interestingly, of course, this is a study with a co-primary endpoint of PCR, and in those patients who'd had a PCR, the overall survival difference between the two groups, so regardless of how you got there, was less than 1% and not statistically significant. In those patients that didn't get to a PCR, regardless of how they got there, if you were in the Pembro arm, you had a 6% better survival than those that didn't have early Pembro. So maybe it suggests there's a benefit beyond achieving PCR. I think this segues quite nicely to a paper that Craig's been reading.
Yeah, it was just, I noticed that you put in the chat that you were thinking of presenting this, and then I came through this morning on one of those table of content feeds, paper from the Journal of Oncology Practice, some real-world data published in the current edition. So we'll put the link to that. It's called Real-World Immune-Related Adverse Events in Patients with Early Triple-Negative Breast Cancer Who Received Pembrolizumab. So it's a retrospective study from a community hospital, patients who received Pembro with chemo between 2021 and 2023, excluding those enrolled in clinical trials. And so there was a ethnically diverse population in the US. 34% of patients had immune-related adverse events, commonly the endocrinopathies and GI. There were about 10% of patients ended up being hospitalized, mostly because of colitis, and 2 patients died. So basically 1% of this population died from their toxicity of the Pembro. And so that just contextualizes that 5% absolute benefit. And I think most patients, especially a younger population, would jump at the 5%. But obviously in the consent process, this kind of data helps contextualize the risk-benefit.
I think that's right, Craig. And I think when I'm dealing with patients who are having IO for melanoma, for example, certainly in the adjuvant setting, I talk about a 5% likelihood of life-altering side effects. Because we've had some patients who have been really, really harmed by immune therapy in terms of neuropathies or pneumonitis or myopathies or whatever. You can get quite a lot of debilitating conditions. Patients who've had type 1 diabetes develop as a result. And it's about 5%, I think, of proper life-changing side effects. And I think that has to be contextualized when you're looking at these quite small benefits as well. So I think you need to really counsel people about the long-term harms. And of course, people naturally will emphasise the importance of disease control and perhaps think less about long-term side effects in the short term, which is why it's important to have that really meaningful conversation about what those long-term toxicities look like.
So in this paper, 20% people ended up with an endocrinopathy. So, they would have stayed on thyroxine or steroids or other agents. So
this is a younger female cohort, and it worries me that that isn't being taken into account. And I do hope and I do congratulate that real world data will continue to be, and real world long term data will continue to be collected, because the vast majority of these women are going to be cured with or without the pembrolizumab. And just like paclitaxel and oxaliplatin have lifelong toxicities for some patients that are miserable, I think we need to take that into account.
I always say to patients, if we had a crystal ball, it'd be easy. And so the message to me is, as a community of researchers, we need to have better biomarkers that might predict toxicity and better predictive factors, that tailor the treatment population so that we actually target those most in need and minimize the risk to those who don't need it. So, it's still early days in the whole field, and I would hope that in the years ahead we get better at being able to tease out an individual patient and help them in that decision-making process.
I think a couple of things too. I think we need to stop talking about treatment minimization and start talking about right sizing, because if I were an unwell person, I don't want my treatment minimized. I want my treatment right size.
I think we should start calling it Goldilocks zone treatment, really.
Yep, just right. But the other thing I had to deal about.
Let's Goldilocks.
Yeah, was it just right? Yeah, that's cute. As Craig, is that you say crystal ball. This is where maybe, we're edging a generation here. Difference is, I always say PlayStation. I say if we could do this 100 times, we'd find the right strategy. But we don't get to do it 100 times.
I don't understand that. Yeah, I didn't get that. So all right. We've got a couple more to finish off. Firstly, in GU, there was a landmark paper in bladder cancer, so perioperative durvalumab with neoadjuvant chemotherapy in operable bladder cancer. So this was presented by Thomas Powles at ESMO. This was a large phase 3 study, 1-to-1 randomization between cisplatin-based chemotherapy with durvalumab given both before treatment, followed by a further 8 cycles afterwards. And it showed the first of the primary endpoints was events-free survival, with overall survival as the key secondary endpoint. But they did have some overall survival data to show. And so that estimated event-free survival at 24 months was 67% in the durvalumab group, 59.8% in the chemo alone group. And the overall survival at 2 years was 82 months in the durvalumab group versus 75%. Interestingly, the grade 3/4 toxicity showed no difference, which I found hard to work out. And the treatment-related adverse events leading to death was 0.6%. More patients who got the durvalumab were able to have radical cystectomy compared to the comparison group. So that was the Niagara study. And, that was the discussant thought this was practice-changing treatment, concurrent New England Journal publication. In absolute terms, there was clear survival advantage, hazard ratios of 0.75. So at 2 years, overall survival 82 versus 75, so 7% benefit and a 0.6% risk of death.
So, Craig, given it was a Niagara study, did they have waterfall plots?
I thought you were going down the Viagra pathway because this was a GU cancer, but...
I thought somebody was going to mention flooding too, but it did.
It's a little bit too soon for that cake to have just been underwater. So, Craig, can I just ask you a question in terms of advanced urothelial cancers? Is there any difference in advanced cancers between the PD-L1s versus the PD-1 agents? So is this the optimal agent to be used in the perioperative strategy, or do you think that PD-1 inhibitors are any different?
I don't think there's ever any data to argue that, Chris. There was a talk at ESMO about not all checkpoint inhibitors are the same, but I think the message that we're seeing in a lot of cancers with people with locally advanced disease, it's the perioperative approach rather than the adjuvant approach that is important. So giving doses, we've seen it in gastric cancer, we've seen it in non-small cell lung cancer, we've seen it now in bladder cancer, we see it in melanoma. So giving some doses, presumably when the immune system's intact, hasn't been damaged by surgery, which is immunosuppressive chemotherapy alone, and lymph nodes intact, that approach seems to be more efficacious than giving some doses afterwards. And the right sizing might be limiting the number of doses, tailoring it. We've got evidence in melanoma. People have had a complete response with the pre-op doses. You don't need the post-op, etc. So maybe that's where we'll get to in these tumours.
That's right. I mean, ensuring that the patient's got the maximum number of neoantigens for the agent to observe, and also, as you are alluding to as well, having the TILs around tumour-infiltrated lymphocytes around in the adjacent nodes and amplifying those really as well, eh? So you've not yet cut those out, which you can then actually maximise too. So I think you're right. The pre-op strategy with having some tumour load does appear to be an important concept.
Yep. And then speaking of durvalumab, I'm going to talk now about a study in limited stage small cell lung cancer, again considered to be potentially practice-changing study. This is called the Adriatic study. So we saw Pacific in the non-small cell lung cancer population, patients receiving durvalumab after chemoradiotherapy. This is Adriatic in the limited stage small cell. So patients without progression after concurrent chemoradiotherapy given a year of durvalumab, and again, it showed significant difference in overall survival, regardless of whether they'd received PCI or not, which is interesting. So, postulate there is that maybe by giving the adjuvant immunotherapy, you may not require prophylactic cranial radiation, or that would be the subject of more debate and analysis. So, in this study, the median overall survival in the intent to treat population was 55 months versus 33 months, or at 3 years it's 56 versus 47%, hazard ratio 0.73. So clear separation of the curves, especially as time went on. This is the interim analysis, so we'll need further follow-up, but it may be that it was called immediate practice changing in the discussion.
Yeah, well, I mean, preoperative chemotherapy in bladder cancer adds, 8% to overall survival compared to surgery alone. So that's a standard, and this is adding 8 further percent. So I guess the case for this is just as strong as the case for neoadjuvant chemotherapy. And
I'll just mention a couple of other things, a couple of new targets in the targeted therapy session. So MTAP deletions, which occur in 15% of cancers. There's a new active agent called AMG 193. It reintroduced the concept of synthetic lethality. So we saw that concept emerge with PARP inhibitors, where patients have lost one homologous repair mechanism gene. And so if you knock out the other one with a PARP inhibitor, you have an effect on the tumor cells, but relative sparing of normal tissue. And so the same concept has emerged in these MTAP deletions with this agent, which creates synthetic lethality in patients that have a MTAP deletion, with a small but clearly active response rate in non-small cell lung cancer, pancreatic cancer, and biliary tract cancers. And then the other target, just to mention, is KRAS G12D. We see a lot of those mutations in patients if they do get their tumours tested with next-generation sequencing. So it occurs in about 1 in 8 colon cancers and 1 in 3 pancreatic cancers. And so this was a selective protein degrader called ASP3082 with clearly an active drug. And so we await further clinical studies. But
well, that's exciting.
Just highlighted to me that, through our knowledge of mutations, that there may be more precision medicine treatments in the not too many years ahead.
Yeah, that's exciting. I mean, G12D, Winnie KRAS mutations are great ones to be able to target, aren't they? It's a
that's right.
tricky one in colorectal, and obviously pancreas would be great to be able to target that there, wouldn't it?
Exactly. And so then I'll just mention one other significant thing. So that was ESMO. And I will mention something outside of the world of ESMO, if I may, and that's the FDA issued a guidance on decentralized clinical trials, or DCTs. So they issued some interim guidance during the COVID lockdown period, and then this is their final guidance, really encouraging the use of telehealth in the conduct of clinical trials with the aim of improving recruitment and improving access to disadvantaged populations, either geographically or otherwise disadvantaged populations. So trialists listening, I'd urge you to have a quick look at this guidance. It's an easy read. It encourages, for example, using telehealth visits for screening patients, for consenting patients, for visits in between doses of treatment, and then working with local providers in a networked way to deliver drug using a risk-based analysis of what's appropriate to deliver remotely. They encourage the upfront design of studies considering the telehealth elements, and they encourage co-design with consumers to answer that question about what's acceptable to deliver remotely and with local providers. They give some guidance on if someone's delivering care but doesn't need to have an in-depth knowledge of the investigational brochure or the investigational product, they don't need to be listed as an investigator. So the big difference between DCTs and the Australasian teletrial model is in Australia, we encourage that delivery remotely, and that who's doing what is documented on the supervision plan, which is like a site delegation log, but across sites. So interesting guidance. And just to blow the old trumpet, the own trumpet. Oh, we're going high tech. So there's no expense spared in the production of this spot. So Elizabeth Wilson, who certainly many of the Australian trialists would know, works with IQVIA, Australia, New Zealand, which is one of the largest CROs in the world. Myself and Sabe Subberson in Townsville wrote a letter to the editor to the Lancet Oncology, pointing out the importance and potential significance of this enabling model of care, and that's been published in Lancet Oncology.
Oh, fantastic. Great coup.
Congratulations.
Thank you.
Ho mai te paki paki.
Oh, that's whatever that means.
Bring on the clapping. Yeah.
So it's been a real cook's tour through a whole lot of wide-ranging papers there, but I think, a significant number of those may well influence practice, especially in the first world. We'll wait and see. But yeah, always great to review some of the hot data from the big conferences.
And how are your Qantas pajamas, Craig? How are they on the flight?
They're great. I've restored my stock of them. My wife wants me to throw out the old ones, but being with all the COVID lack of travel, it's been they've been wearing out. So now I've got a couple of pairs of new Qantas pajamas, which are fantastic. I'm wearing them as we speak.
The audience really needed that.
We're so lucky there's no video.
Yeah. Audience is just going wild with that. We now ask ChatGPT to come up with a picture of Craig Underhill. That's our favourite.
On that note, we might say goodbye. So thanks very much. But thanks to all our listeners. If you're enjoying the podcast, please spread the word. Thanks, Rachel, for the production.
My pleasure.
Thanks, everybody, and we'll see you all in a few weeks. Or we'll listen to you all in a few weeks.
Thank you for tuning in to the Oncology Journal Club Podcast, proudly brought to you by the Oncology Podcast, part of the Oncology Network. For healthcare professionals seeking regular news updates and insightful discussions, we invite you to join our community at oncologynetwork.com.au. Your free registration includes a complimentary subscription to our weekly publication, the Oncology Newsletter, a valuable resource to stay updated on the latest advancements in the field. We value your input and welcome your feedback and paper recommendations via our social media channels, email and website. Your insights help shape the conversation and drive the direction of future episodes. This is Rachel Babin signing off for the Oncology Journal Club podcast.